Thank you, Mr. Chairman. Good afternoon, everybody. So it's a real pleasure to be here and would like to thank the organizing committee for inviting me. Extrahepatic solid metastasis is not a very easy talk. So just for fixing about the idea of what is extrahepatic disease, you know that half of the patients develop liver metastasis, but 10 to 20 pulmonary, 15% lymph node, 5% peritoneum, bone 4 to 6, and brain 1 to 4. So this gives us an idea about, I would say, the hierarchy of the extrahepatic disease. As you know, for liver metastasis, which is the more frequent, resection is the best mean of long-term survival as compared to the absence of any resection. And so the first point that rises, the first question, is what about surgery of extrahepatic disease alone? This is not so frequent, but what we know is that for pulmonary resection, isolated pulmonary resection, what we see that in fact we have improved the result according to the recent period is here as compared to here, and a better selection of patient, associated chemotherapy, and repeated metastasectomy is the key, I would say, element for obtaining a good outcome. For peritoneal disease, in the absence of, I would say, liver metastasis, it has been very well demonstrated that cytoreduction plus IPEC, although IPEC is today a little bit a question, provide a 51% 5-year survival. And this is totally amazing, okay? Oligometastatic colorectal cancer for bone colorectal metastasis is very infrequent, but it's happened. And the survival is usually poor, but sometimes resection, as you can see here, may lead to 3-year disease-free survival. And for brain metastasis, still more infrequent, sometimes to resect the brain metastasis, as demonstrated in this case, it offers, I would say, the best chance of long-term survival. So to the question, is surgery of extrahepatic disease alone worthwhile? We may respond, yes, provided that the resection is potentially curative. But as you know, the presence of extrahepatic disease is much more concomitant to that of liver metastasis. And so the first question is, does the presence of concomitant extrahepatic disease impact outcome of liver resection? And for that, if we consider extrahepatic disease overall, you know that in the past, this was an absolute contraindication. And here you have the still a proposal of resecting only in the absence of extrahepatic disease, but some pioneering group has been showing that 5-year survival was possible, providing a resection, sequential resection of liver and extrahepatic. And one of the most first important series was that of Dominique Elias, who showed that finally in 100 patients, the 5-year survival was 20%, not so bad, and 28% when the resection has been curative. We did some years after the same analysis with a little bit more patient, 186, showing that the survival was 28%, of course much lower than that of liver-only disease, with also a chance of long-term disease-free survival. And the memorial here published exactly the same hope of long-term survival, 28% 5-year at long term, with extrahepatic disease concomitant to that of liver disease. This is also the same multi-institutional analysis. We divided by 2 the chance of long-term survival, but to obtain 26% at 5 years rather than almost 0 is still, I would say, notable. Now we have metastatic sites concomitant to liver metastasis, which are real controversial. And one of them is peritoneal disease. And the question is, should unexpected peritoneal carcinomatosis be resected when you discover it at the time of resection of colorectal liver metastasis? As you know, these, when you have more than 3 metastases on the liver, I would say those who do cytoreductive surgery consider this as an absolute contraindication. But sometimes we have been faced planning an hepatic resection with a limited peritoneal disease, and we have taken the option to do the resection when both sites were resectable. And by doing this for limited peritoneal disease, we were able to show that the survival was 18% at 5 years, much better than no resection at all. Another site which is really controversial is that of lymph nodes concomitant to liver disease. And as you see in this review from the BGS in 2000, a lot of studies, but finally a very small series with more than 10 patients and only five-year survivors. So this explains why this has been considered for a long time as a contraindication. We did an analysis in our institution showing, of course, that liver only was much better, but even resecting liver plus lymph node in those patients responding well to chemotherapy was associated with an intermediate survival of 18%. But important to consider was the sites of the lymph node. Hepatic lymph node, celiac lymph node, retroperitoneal lymph node are different. And in our study, we show that, in fact, for pedicular lymph node concomitant to liver metastasis, we obtained 25% 5-year survival, but it was 0 for celiac and 0 for retroperitoneal. And so I would say this has been confirmed for the relatively good prognosis of pedicle, I would say, lymph node in the group of Strasbourg with 18% 5-year survival, 10% disease-free. But for retroperitoneal, I have been really surprised to see this very, very good result of the group of Lyon, showing that even for retroperitoneal lymph node metastasis of colorectal cancer, they observed a very good 5-year survival and a PFS also very good for retroperitoneal metastasis. So possibly I should review a little bit, revisited my contraindication for retroperitoneal. And if you want to be extreme, I have been very interested by this publication where they remove the aorta for making an efficient lymphadenectomy. I don't know if you would like to do it, but it has been done with apparently a good result. So to the question, does the present impact outcome? We can say yes, but long-term survival is possible when resection is complete. Third question, does the site of extrahepatic disease has a role? And if I ask this, is because Dominique Elias was a little bit provocative by publishing this paper, saying that what is important is the total number of metastases, irrespective of their location. And he did a paper showing apparently this. I don't think that today we may say that, because here in this paper of Pulitano, you see that liver only and liver plus extrahepatic disease, unquestionably extrahepatic disease, had a prognostic impact on, and particularly for the site. Also, we show that for lung metastasis, the survival is much better than for lymph node associated to liver metastasis, much better than for multiple sites. And this is also confirmed by the Memorial Sloan Kettering experience, showing that the survival may go from 11% to 26% according to the different, I would say, sites of metastasis. And if we see the LiverMet survey evaluation, which is the International Registry on Liver Metastasis, you can see that by order of gravity, the best one is the lung, the second is the lymph node, the third is the peritoneal, and the fourth is the multiple site. So the site of extrahepatic disease influence, I would say, the prognosis of patient with the following order: lung, lymph node, peritoneum, and multiple site. Now, a very recent question is the rationale to resect liver metastasis in the presence of unresectable liver metastasis. As you know, we have been educated with the, I would say, oncologic principle of liver surgery, the law of all or nothing, whether we resect all or we should not resect. Why? Because this is a paper, old paper of Chile, show that for no resection or palliative resection, the results were the same, much different from that of curative resection. But the MD Anderson recently suggests a new concept to do complete liver resection without resecting synchronous lung metastases. Is it justified? And they show that, of course, here the best is to resect the site. Of course, the much worse result is when you do no resection at all, but by resecting the liver without resecting the lung metastasis, the survival curve was intermediate. And so they said, this possibly justifies the fact to do resection of the liver without resecting the lung. And we did a similar, I would say, study in the Liver Met Survey registry, showing that in red, the best is liver only, that the lower curve is when you don't resect the liver, you don't resect the lung, but also an intermediate survival curve is observed when you resect the liver, without resecting the lung. So today, what can be said that it is possible that there may be a rationale to resect the liver without resecting the lung. Now, which patient will benefit from combined resection? We did in this study the evaluation of the prognostic factor, 5, the right column first. At that time, we don't know why it emerged as a prognostic factor. Today, we know. Liver recurrence, more than 6 colorectal liver metastases, the CEA level more than 10, and the absence of other than lung metastases. And we come to the conclusion that according to the number of factors, the 5-year survival was, of course, very different, coming from 63% when you have none of these independent risk factors to 0 when you have all these risk factors. And we propose that not to have more than 2 risk factors if you want to observe any benefit in survival by sequential resection of liver and extrahepatic disease. The group of the Memorial also did such type of analysis and showed that, of course, the number as we did, the site as we did, were important, but they added the size of the largest colorectal liver metastasis, more than 3, and they come also to predict the possibility of long-term survival. And also something which is important for us as surgeons is there a possibility of curing this patient? Because very often we do the resection, but we say we have no possibility of cure. It is wrong. We have a possibility of cure, and recently we did a study where, by reviewing all our cases with extrahepatic and hepatic disease, 13% on an intention to treat patient were potentially cured, 19% in those who had a complete resection, taking as a definition of cure all the patients disease-free from more than 5 years after the last treatment. And so I would say to conclude that isolated extrahepatic disease should be resected if the resection is complete. Concomitant extrahepatic metastasis should not be anymore considered as a contraindication for liver resection, provided that the overall strategy is potentially curative. An aggressive oncosurgical approach, chemo plus sequential surgery, is the only hope of long-term survival, 22 to 28% at 5 years. The site of extrahepatic disease has an impact on outcome, and extrapedicular lymph node and peritoneal carcinomatosis have worse outcome than lung metastasis, but still, resection may improve the prognosis. A rationale may exist, finally, to resect liver metastasis even with unresectable lung metastasis. And of course, all this need multidisciplinary management. Why? Because liver plus extrahepatic mean aggressive or advanced disease, and the absolute need of good control by systemic chemotherapy before any surgery. A close collaboration between oncologist and surgeon for the decision-making process, the optimal combination of treatment and the timing. Different surgical specialties may also be involved in the MDT, colorectal, hepatic, thoracic, neurosurgical, orthopedics, but the prerequisite for any surgery is a response to chemotherapy, but also a fighting spirit from each physician involved in the process for an aggressive oncosurgical approach. We should not be dogmatic, but to take the decision on a multidisciplinary decision, all the most that today, with molecular biology, we come to introduce, I would say, the molecular biology in the prognosis of patients, as demonstrated here, and Nick Voté will speak on it, the influence of the RAS mutation on the bad result that we may observe after hepatic resection, as well as also the BRAF mutation. So, multidisciplinarity, the old one was gastroenterologist, medical oncologist, radiologist, and surgeon. With expertise, we come to a specialized liver surgeon and a colorectal surgeon at least. And today, the molecular biologists, the pathologists, and the radiotherapists are still and also a very important point to offer the best treatment at the best timing for these patients with extrahepatic disease, which are really usually a poor prognosis. Thank you for your attention.